Imagine, for a moment, that you are standing on dry land. You are in your living room, or perhaps lying in your own bed. The air around you is clear. But your body tells you a different story. Every time you try to take a breath, it feels as though a heavy weight is pressing down on your chest. You gasp, but the air doesn't seem to reach the bottom of your lungs. It feels like you are drowning, but there is no water to be seen. This terrifying sensation is the daily reality for millions of people suffering from one of the most prevalent and deadly conditions in modern medicine, acute heart failure. It is a condition that doesn't just whisper, it screams. It sends people rushing to the emergency room in the middle of the night, gasping for air, their ankles swollen to twice their normal size, their bodies flooded with fluid that their hearts are simply too weak to pump away. And here is the tragedy of this condition. It is often a revolving door. A patient arrives at the hospital, they are treated with powerful diuretics, medications that force the kidneys to flush out water, and after a few days, they feel better. The fluid leaves their lungs. They can breathe again. They are discharged with a wave and a prescription, sent back home. But the clock immediately starts ticking again. For many, the underlying problem hasn't been solved, it has only been paused. Within 30 days, a staggering number of these patients will be back in that same hospital bed, fighting for breath again. Or worse, they won't make it back at all. For decades, the medical community has been asking a desperate question: is there a way to break this cycle? Can we intervene earlier, more aggressively, and more safely, right when the patient is most vulnerable? Today, we are going to tell the story of a clinical trial that sought to answer that very question. It is a study that challenged the old way of doing things. It asked whether a drug, originally designed for diabetes, could be the key to saving hearts that are in the midst of a catastrophic failure. This is the story of the EMPULSE trial. Now, before we dive into the data, we need to understand the beast we are fighting. Acute heart failure is not a single disease, it is a clinical syndrome. It happens when the heart muscle is unable to pump enough blood to meet the body's needs. Because the pump is failing, blood backs up. It backs up into the veins, causing the jugular vein in the neck to bulge. It backs up into the tissues, causing the legs to swell. And most dangerously, it backs up into the lungs, filling the microscopic air sacs with fluid. This is what doctors call congestion. For a long time, we treated this by simply trying to dry the patient out. We used loop diuretics, drugs like furosemide, that act like a chemical wringout for the kidneys. And while this works to relieve symptoms, it doesn't always fix the long-term outlook. The heart is still weak. The kidneys are still under stress. Enter a new class of drugs with a name that is quite a mouthful: sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors for short. You might have heard of them. Drugs like Empagliflozin, pronounced Empagliflozin. Originally, these were designed to help people with type 2 diabetes. The mechanism was clever but simple. The drug blocks a specific protein in the kidneys that reabsorbs sugar. Instead of going back into the blood, the sugar is peed out. And where sugar goes, water follows. So, these diabetic patients started losing a little bit of fluid. But then, researchers noticed something strange. Something wonderful. The patients with diabetes who were taking these drugs weren't just controlling their blood sugar. Their hearts were getting stronger. They were dying less often from heart disease. They were staying out of the hospital. This discovery sent shockwaves through the cardiology world. Suddenly, everyone wanted to know, could this diabetes drug work for heart failure patients who didn't even have diabetes? We saw trials like EMPULSE reduced and DOP-HF prove that, yes, these drugs are incredible for chronic heart failure. But there was still a massive, dangerous gap in our knowledge. All those previous big studies looked at patients who were stable. Patients who were walking around, living their lives, perhaps seeing their doctor for a routine checkup. But what about the patients in the ambulance? What about the patients lying in the hospital bed, hooked up to monitors, having just survived a near-fatal episode of fluid overload? Is it safe to give a powerful new drug to someone whose body is in such a fragile state? Or would it be too much? Would it cause their blood pressure to crash? Would it damage their kidneys? This is where the EMPULSE trial comes in. It was designed to go where other trials hadn't dared. It wanted to test the safety and efficacy of starting empagliflozin right inside the hospital walls, before the patient is even sent home. The implications of this are massive. If you can start a life-saving therapy early, you might prevent that revolving door of readmission. You might save thousands of lives. But if you're wrong, you could make unstable patients even worse. So, let's walk through exactly how the researchers set up this high-stakes experiment. To answer this question, an international team of researchers designed a randomized, double-blind, placebo-controlled trial. These are the gold standard words in science. Randomized means patients were picked by chance to get the drug or not. Double-blind means neither the doctors nor the patients knew who was getting the real medicine, eliminating bias. They recruited exactly 530 patients. Now, 530 might sound like a small number compared to the mega trials of 5,000 or 10,000 people, but in the setting of acute care, where patients are very sick, this is a significant undertaking. Let's look at who these people were. This is the inclusion criteria, the scientific checklist of who gets to join the study. First, they had to be in the hospital with a primary diagnosis of acute heart failure. This means their main reason for being there was that their heart was failing. Second, they had to be suffering. The study required them to have dyspnea, which is the medical term for shortness of breath. Third, they needed objective proof of fluid overload. The researchers didn't just take the patient's word for it. They looked for at least 2 physical signs. This could be rales, a crackling sound in the lungs heard through a stethoscope. It could be edema, swelling in the legs where, if you press your thumb into the skin, the indentation stays there. Or it could be distended neck veins. Fourth, they looked at the blood work. They measured something called NT-proBNP. Let's pause on that term for a second, NT-proBNP. This is a biomarker. When the heart muscle is stretched and stressed, when it's working too hard against too much pressure, it releases this substance into the bloodstream. It's like a distress flare sent up by the heart. A high level of NT-proBNP confirms that the heart is in trouble. For this study, patients needed a level of at least 1,600, or even higher if they had an irregular heartbeat like atrial fibrillation. But here is the most critical part of the study design, and the part that makes EMPULSE unique. They didn't just give the drug to anyone the moment they rolled through the emergency room doors. That would be reckless. Instead, they waited for stabilization. You see, when a patient first crashes with heart failure, their blood pressure might be wildly fluctuating. They might be on intravenous medications to force the heart to beat harder. It is a chaotic time. The researchers defined a strict window of clinical stability. A patient could only be randomized into the trial if they met these specific safety checks. 1. Their systolic blood pressure, the top number, had to be at least 100 millimeters of mercury. We couldn't risk dropping the pressure of someone who was already hypotensive. 2. They could not be on any intravenous vasodilators, drugs that open blood vessels, for at least 6 hours. 3. They could not be on inotropes, drugs that whip the heart to beat faster, for at least 24 hours. 4. Their dose of diuretics, the water pills, had to be stable. Basically, the doctors had to get the patient through the worst of the storm first. Once the storm had passed, but while the patient was still in the hospital, between 24 hours and 5 days after admission, that is when the trial began. Half the patients received 10 milligrams of empagliflozin once a day. The other half received a matching placebo pill that did absolutely nothing. They treated them for 90 days. Now, you might be asking, what were they looking for? Did they just count how many people died? Well, in the old days of cardiology, yes. We used to look at time to death. But heart failure is complex. Some people don't die, but they live in misery. Some survive but spend every other week in the hospital. Some stay home but can't walk to the mailbox without gasping. So, the EMPULSE researchers used a sophisticated statistical tool called the stratified win ratio. This concept is fascinating, and it is crucial to understanding why this trial matters. Imagine you take one patient from the Empagliflozin group, let's call him patient A. And you take one patient from the placebo group, patient B. You compare them head-to-head in a duel. Who wins the duel? The rules of the duel are a hierarchy, a ladder of importance. Step 1 is death. Did patient A survive while patient B died? If yes, patient A wins. The comparison is over. We don't care about anything else because survival is the most important thing. But what if both patients survived? Then we move to step 2, heart failure events. Did patient B land back in the hospital for heart failure, while patient A stayed home? If yes, patient A wins. What if they both stayed out of the hospital? Then we move to step 3, time to event. Did patient B go to the hospital sooner than patient A? And finally, if they were tied on all those medical counts, we move to step 4, quality of life. The researchers used a survey called the Kansas City Cardiomyopathy Questionnaire, or KCCQ. It asks questions like, how much does your heart failure limit your enjoyment of life, or how often do you have swollen ankles? If patient A's score improved significantly more than patient B's, then patient A wins. They did this comparison for every possible pair of patients in the trial. Thousands upon thousands of comparisons. This win ratio approach allows the study to capture the full human experience of the disease. It acknowledges that while staying alive is the ultimate goal, living well and staying out of the hospital are also huge victories for patients and their families. So, 530 patients. 90 days. A hierarchy of winning. What did they find? The results of the EMPULSE trial were published to great anticipation, and they did not disappoint. When the statisticians ran the numbers on that win ratio we just discussed, the result was striking. Patients who received empagliflozin were 36% more likely to experience a clinical benefit compared to those taking the placebo. Let that sink in. A 36% better chance of winning the duel against the disease. In the world of clinical trials, where we often get excited about a 5% or 10% improvement, 36% is a robust, powerful signal. The win ratio was reported as 1.36. Statistically, this was highly significant, with a p-value of 0.0054. For those of you who aren't statistics nerds, a p-value below 0.05 is usually considered the threshold for scientific truth. A 0.0054 means there is an incredibly tiny chance that this result was just a fluke. It is real. But let's break down why they won. Was it just because they felt better? Or did it actually save lives? The beauty of the win ratio is that we can look at the components. First, let's look at death. In the group taking empagliflozin, 4.2% of patients passed away from any cause during the 90 days. In the placebo group, that number was 8.3%. Now, because the study was relatively small, only 530 people, it wasn't technically powered to prove a mortality difference on its own. However, seeing the death rate cut nearly in half, from over 8% down to roughly 4%, is a very encouraging trend that aligns with what we've seen in larger studies. Next, heart failure events. These are the readmissions, the unplanned trips to the ER, the moments of panic. In the empagliflozin group, 10.6% of patients had a heart failure event. In the placebo group, it was 14.7%. Again, a clear separation. The patients on the drug were staying home and staying stable more often. And finally, quality of life. This is the one the patients feel every morning. The researchers looked at the change in the KCCQ score. Remember, this is the survey about symptoms. Both groups got better. This is expected, they were in the hospital receiving care, so naturally, they would improve compared to when they were admitted. But the empagliflozin group improved significantly more. The difference between the two groups was 4.5 points in favor of the drug. To put that in perspective, a 5-point change is usually considered clinically meaningful. It's a difference a patient can actually notice, like being able to walk to the bathroom without stopping, or sleeping flat without coughing. So, the drug worked. It helped people survive, it kept them out of the hospital, and it made them feel better. But there is another layer to these results that is perhaps even more important than the top-line number. It's the who. Who did this drug help? Was it only the diabetics? Was it only the people with really weak hearts? The researchers did a subgroup analysis. They sliced and diced the data to see if the drug worked better in some people than others. They looked at patients with type 2 diabetes versus those without. The result? The benefit was identical. It didn't matter if your blood sugar was high or normal. Empagliflozin worked for both. This reinforces the idea that this is not just a diabetes drug anymore, it is a heart drug. They looked at de novo versus decompensated chronic heart failure. De novo means new. These are patients crashing with heart failure for the very first time in their lives. Decompensated chronic means patients who have had heart failure for years and are having a flare-up. Historically, de novo patients are hard to study because we don't know their history. But in EMPULSE, both groups benefited. Whether it was your first day with heart failure or your 1000th, the drug helped. And perhaps most importantly, they looked at ejection fraction. Ejection fraction, or EF, is a measurement of how much blood the left ventricle pumps out with each beat. A normal heart pumps out about 50 to 70%. Usually, heart failure is divided into reduced ejection fraction, the pump is weak and flabby, and preserved ejection fraction, the pump is stiff and thick. For decades, we had no treatments for preserved ejection fraction. None. But in the EMPULSE trial, it didn't matter. Whether the EF was low or high, the win ratio favored empagliflozin. This is a pan-heart failure therapy. It seems to work across the entire spectrum of the disease. So, we have established that the drug is effective. It works broadly. It works quickly. But the elephant in the room remains. Is it safe? Remember, these patients are fragile. Their kidneys are often on the brink of failure. Their blood pressure is often borderline. Did giving them this drug push them over the edge? When you introduce a therapy that changes how the kidneys handle salt and water, safety is the #1 concern. The researchers monitored adverse events meticulously. They were specifically looking for a few scary possibilities. First, volume depletion. Since empagliflozin makes you pee out sugar and water, there is a risk that you could dry the patient out too much. This leads to dehydration and low blood pressure. In the trial, volume depletion occurred in 12.7% of the empagliflozin group, compared to 10.2% in the placebo group. So, yes, it happens slightly more often with the drug. This makes physiological sense. However, the difference was small, and importantly, it was manageable. It rarely led to the patient having to stop the drug. It just meant the doctors had to adjust their other diuretics. Second, acute kidney injury. This is the big fear. If you drain too much fluid, the kidneys can shut down. Surprisingly, the rate of investigator-reported acute renal failure was actually lower in the empagliflozin group, 7.7%, compared to the placebo group, 12.1%. Wait, how can that be? How can a diuretic-like drug save the kidneys? It turns out that by relieving the congestion, by reducing the pressure in the veins that drain the kidneys, SGLT2 inhibitors actually help the kidneys breathe. A congested kidney is an unhappy kidney. By decongesting the body, you protect the renal system. Third, ketoacidosis. This is a rare but dangerous side effect seen in diabetic patients on these drugs, where the blood becomes acidic. In EMPULSE, there were 0 cases. None. This was incredibly reassuring. Fourth, Hypoglycemia, low blood sugar. Since the drug lowers blood sugar, could it cause dangerous drops in people who don't have diabetes? The data showed that hypoglycemia was rare and occurred at the same rate in both groups, about 1.5% to 1.9%. This confirms that SGLT2 inhibitors have a smart mechanism. They lower high sugar, but they don't generally push normal sugar down to dangerous levels. Overall, fewer patients in the Empagliflozin group had serious adverse events compared to the placebo group, 32.3% versus 43.6%. Let me repeat that because it is counterintuitive. The people taking the active drug had fewer serious bad things happen to them than the people taking the sugar pill. This suggests that the disease of untreated heart failure is far more dangerous than the side effects of the medication. We have discussed the what and the who. Now, I want to take a few minutes to dive into the how. Why on earth does a kidney drug fix a broken heart? This is one of the most fascinating areas of modern medical research, and while we don't have all the answers, we have some compelling theories that explain the success of EMPULSE. The most obvious mechanism is diuresis, fluid loss. When you take empagliflozin, you excrete glucose in your urine. Glucose is an osmole, it attracts water. This causes osmotic diuresis. But unlike traditional diuretics like furosemide, which drastically change the salt balance and volume of the blood, SGLT2 inhibitors seem to remove fluid essentially from the interstitial space. Imagine your body is a sponge. Traditional diuretics squeeze the water out of the blood vessels. If you squeeze too hard, the blood vessels collapse, blood pressure drops, and the kidneys panic. SGLT2 inhibitors seem to gently pull the fluid out of the tissues, the swelling in the legs, the fluid in the lungs, while keeping the blood volume relatively stable. This is called interstitial decongestion. It's a smarter way to dry out the body. But there is more to it than just water. There is energy. The failing heart is like an engine running out of fuel. It struggles to burn glucose efficiently. SGLT2 inhibitors increase the production of something called ketone bodies. You might have heard of ketones from the trendy keto diet. Ketones are a superfuel for the heart. They are oxygen efficient. By slightly raising ketone levels, the drug might be providing a high-octane energy source to the starving heart muscle, helping it pump more effectively without working harder. Furthermore, there is the sodium-hydrogen exchanger. This is a microscopic pump on the surface of heart cells. In heart failure, this pump gets overactive, leading to toxic levels of sodium inside the heart cells, which ultimately kills them. There is evidence that SGLT2 inhibitors dampen this pump. They directly protect the heart muscle cells from dying. This multi-pronged attack, smart fluid removal, better fuel efficiency, and direct cell protection, is likely why we see such consistent benefits across all types of heart failure. So, what does the EMPULSE trial mean for the future of medicine? Why should you, or your doctor, or the healthcare system care? Before EMPULSE, the standard practice was often stabilize and discharge. We would get the water off the patient, make sure they could breathe, and send them home with a prescription for their old meds, maybe planning to start new ones later in the outpatient clinic. The problem is, later often never comes. Clinical inertia sets in. Patients get tired of taking pills. Doctors hesitate to change things if the patient seems okay. EMPULSE completely shatters that paradigm. It tells us that the hospital stay, that vulnerable window of 24 to 5 days after admission, is the perfect time to start this life-saving therapy. We don't need to wait for discharge. We don't need to wait for a follow-up visit. By starting in the hospital, we ensure the patient is actually on the drug. We can monitor them for those first few doses. And we send them home with a layer of protection they didn't have before. The study supports a strike early, strike strong approach. It also simplifies things. Because the drug worked regardless of ejection fraction and regardless of diabetes status, doctors don't need to agonize over complex flowcharts. Is the patient in the hospital with heart failure? Are they stabilized? Is their kidney function acceptable, eGFR greater than 20? If yes, start the drug. This simplicity is revolutionary. It removes barriers to care. Since the publication of EMPULSE and its sister trials, international guidelines have shifted. Major cardiology societies in Europe and America now recommend SGLT2 inhibitors as a foundational pillar of heart failure care, including initiation during hospitalization. We are moving away from the era of simply managing symptoms and into an era of modifying the disease itself. The story of the EMPULSE trial is a story of hope. It is a story of taking a terrifying condition, the drowning sensation of acute heart failure, and fighting back with rigorous science. It shows us that even in the most fragile moments of hospitalization, the human body can respond to the right therapy. It reminds us that innovation often comes from unexpected places, finding a heart cure inside a diabetes drug. As we close, please remember that this narration is for educational and informational purposes only. It is not medical advice. Heart failure is a serious, complex condition. If you or a loved one are suffering from symptoms like shortness of breath, swelling, or fatigue, you must speak with a qualified healthcare professional. Never start or stop a medication based on a video or an internet script. Science is always moving forward. Yesterday, we treated the symptom. Today, we treat the cause. And tomorrow? Who knows what we will discover? Thank you for watching.